Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
This program is presented by Medscape Education Global.
Hello, I'm Barbara Wildhaber, professor and surgical head of the Swiss Pediatric Liver Center at the University Hospitals of Geneva in Switzerland. Welcome to this program titled Challenges and Opportunities in the Diagnostic Pathway for Biliary Atresia. Joining me today are Philip Buffler, professor, director, and head of the Department of Pediatric Gastroenterology, Nephrology and Metabolic Medicine at the Charité, Universitätsmedizin Berlin in Germany. And then we have with us Laure Doré, director of the French patient organization AMFE, Association Maladie du Foie depuis l'Enfance. This is the French Association for Pediatric Onset Liver Diseases in Paris, France. And last but not least, we have Muriel Girard, associate professor, researcher at the French National Reference Center for Rare Diseases, Biliary Atresia, and Genetic Cholestasis at the Hôpital Necker, Université de Paris in France. Welcome. So why it's important to cover this topic? Biliary atresia is a rare neonatal condition that leads to severe cholestasis and, if untreated, rapidly to biliary cirrhosis. Typical signs, symptoms include jaundice, pale stools, and dark urine. The Kasai portoenterostomy is the primary therapeutic intervention for most children, and it's more likely to work if performed earlier. Biliary atresia is the most common indication for pediatric liver transplantation. If left untreated, biliary atresia can lead to death within the first years of life. It is therefore critical to recognize the signs of biliary atresia and understand and to refer to specialists. So, Laure, as a patient advocate, what is the impact of a delayed diagnosis of biliary atresia?
Yes, Barbara, delayed diagnosis of BA has very serious consequences. We know that the success of Kasai procedure is much higher when diagnosis is made early, and the best outcomes are observed when the Kasai procedure is performed within the first 30 to 45 days of life. When diagnosis is delayed, the chance of success decreases. If the Kasai procedure fails, many children will require a liver transplant, often within the first 2 years of life. The liver transplant leads to complex medical care, long or frequent hospitalization, and intensive long-term follow-up. All of them can have a major impact on the child's quality of life. But the consequences also extend to the entire family. Parents often need to reorganize their professional lives, siblings are affected, and families may experience significant emotional stress as well as financial and social difficulties.
Thank you very much, Laure. And now, Philip, from a clinical standpoint, why is it critical to diagnose biliary atresia early and intervene quickly?
As you just mentioned, without treatment, biliary atresia progresses to end-stage liver disease and need for a liver transplantation within the first 2 years of life. In Europe and the US, biliary atresia is the most common indication for liver transplantation. And in Europe, 45% of the pediatric liver transplantations are performed annually for biliary atresia. In the US, it's slightly different. There are about 60% of liver transplantation children account to biliary atresia. Up to 10% of children die while waiting on the liver transplantation list. And that's a huge problem.
Thank you, Philip. Well, Muriel, now, do you want to comment on what is the urgency in suspecting biliary atresia?
Yes, of course. BA diagnosis is an emergency because an earlier diagnosis significantly increased the success rate of the Kasai procedure. The key diagnosis finding is alcoholic stools because this is signifying complete cholestasis, suggesting bile duct obstruction or severe cholestasis. And in case of alcoholic stools, the emergency is injection of vitamin K to avoid bleeding episode. And to confirm or rule out biliary atresia, it is essential to search for extrahepatic bile duct obstruction. Patients should be referred to a reference center that can establish the diagnosis as quickly as possible and perform Kasai procedure without delay. If BA is not confirmed, the reference center will investigate differential diagnosis.
Thank you, Muriel. Well, you may remember now that we mentioned that the Kasai procedure is the primary therapeutic intervention, this portoenterostomy, for most children, and it's more likely to work if performed earlier. What you can see on this graph, on the x-axis, you see that it's time, and on the y-axis, you have the survival with native liver after the Kasai operation. So that's one of the measurements we aim for when we have our biliary atresia patients, because we want them to live with their own liver as long as possible. And what we can see here are the different lines. They show the different age when Kasai was performed. And we can see that the Kasai procedure performed before 30 days of life correlates with best outcomes. It's early, so ideally the Kasai procedure should be performed before 30 to 45 days, so 5 to 7 weeks of age to achieve higher survival with native liver. So the early diagnosis of biliary atresia is critical to achieve best possible outcomes and prevent complication. And so let's now talk about best practice for a prompt diagnosis. And let's start by discussing screening. Laura, your association has been involved in promoting early screening for biliary atresia. And as a patient advocate, what are key considerations for screening that you'd like to highlight? Very important topic because the parents are the first ones who see the patient.
Thank you for asking about screening, because early screening for BA starts with recognizing a few key warning signs. A jaundice that persists beyond 2 weeks of life should always be investigated. This is especially important when persistent jaundice is associated with pale stools or dark urine, as it may indicate neonatal cholestasis. It is also important to remember that many babies with biliary atresia may grow and gain weight normally during the first weeks of life, which can sometimes delay suspicion. Pale or discolored stools are a typical hallmark of cholestasis. In practice, non-specialist physicians may not always be alerted by the presence of pale stools, so when a newborn presents with jaundice, it is essential to check the color of the stools. One practical point is to use a tongue depressor to check the inside of the stools, as dark urine can stain the surface and falsely suggest that the stool is not pale. Normally, stools in infants are bright in colors. Therefore, if stools are colored but not bright in colors, they should be considered abnormal. We develop educational video that can help parents and healthcare professionals to recognize these warning signs early, and this video can be accessed through the link provided here.
Thank you, Laura. Now, Muriel, how can parents, primary care physicians, and midwives assist in the early screening for biliary atresia?
Yes, in addition to pale stools, other warning signs include jaundice and dark urines. Physiopathological jaundice and breastfeeding related jaundice are common, but pale stools and dark urines are key to suspect biliary obstruction. In case of pale stools, the baby needs to be referred to a pediatric gastroenterologist center. What is the mechanism of stool discoloration? As the bile ducts are totally obstructed, the bile is not going into the intestine. So the stools are very pale. And when the cholestasis is present, we can observe that the skin and sclera are yellowish, and it is necessary to observe stool color. Babies with abnormal stool should be sent to pediatric physician consultation and referred to a pediatric gastroenterologist.
So now we really know it's important to look at that poop. But now, Philip, are there any screening guidelines for primary care physicians, and when should conjugated bilirubin be assessed?
Yes, absolutely. Thanks. So just let me shortly introduce the US-based guidance and the ASPIGAN recommendation in Europe. So the US guidelines, they just tell check the eyes, check for yellow eyes or jaundice. Then check the poop, whether the stools are pale, gray, or white. And then you're gonna ask whether there was some bilirubin taken right after birth and whether this value was just above the laboratory range. And if yes, of course, you also need to repeat the conjugated bilirubin measurement. Aspirin is kind of slightly different. So in Aspirin, the focus is on jaundice, the length of jaundice. So if the jaundice in a healthy newborn baby is longer than 2 weeks of age or no later than 3 weeks of age if breastfed, then you should look for elevated conjugated bilirubin. That's the procedure. In Germany, we're also talking about this kind of approach, but we also include the stool color card in order to recognize the pale stools more easily. And as mentioned before as well, in case of suspected cholestasis, you have to administer an urgent vitamin K injection to reduce the risk of bleeding.
Thank you, Philip. And I actually realize maybe our listeners do not realize why we have to give vitamin K in case of cholestasis. You may want to explain?
The problem is that we need the bile acids for fat absorptions. If there are no bile acids, then the absorption of fat as well as fat soluble vitamins is impaired. And vitamin K is a classical fat soluble vitamin. So if there are no bile acids, vitamin K cannot be absorbed. And vitamin K is mandatory for the liver to synthesize the blood coagulation factors.
Thank you very much, Philip. And so you have realized we are from 3 different countries, from France, from Germany, from Switzerland. And now I would like to know how is the screening done in Germany? You mentioned you combine stool color, and how is it done in Germany?
Yes, in Germany, actually, we stick to the ASPIGAN guidelines, but we also introduced in 2024 the stool color card, which facilitates the recognition of pale stools, which is also very important.
Thank you, Philip. Muriel, in France, how are the specific things in France?
Yes, in France, we use stool color cards also, as in Germany and Switzerland. We think that it is very useful, but probably not so used by medical centers. And another point which is very important is the highly centralized center that we use. And as we suspect the diagnosis of biliary atresia, the management is very quickly and appropriately driven on a specialized center.
In Switzerland, we introduced the stool color card in 2009, just gave it out to midwives and they gave it to parents. And now it's actually included in the health booklet. And what we did recently, we analyzed data before and after, including it in the health booklet. And we have a dramatic, significant decrease of age, which is good, of diagnosis of biliary atresia, now having integrated the stool color card in the health booklet. And yeah, I think we do still need to improve the screening, and but we're on a good way. And I think all together we will get there, hopefully. Now, Laura, well, you heard about this screening as well, and I know you're an advocate for this, but there's still pitfalls. What are the key pitfalls that should be avoided in this situation?
Yes, Barbara, I see at least 4 pitfalls that should be avoided. First, in infants fed exclusively with milk, whether breastfed or formula fed, stools should always be bright in color. Pale or discolored stools should raise suspicion of cholestasis regardless of the type of feeding. Number 2. In case of cholestasis, dark urine may stain the surface of the stool and falsely give the impression that the stool is normally colored. One more thing, we must remember that urine of healthy newborns is never dark. Number 3. In the maternity ward, a normal Billy flush reading after phototherapy may provide false reassurance. This device measures total bilirubin transcutaneously, but does not specifically access conjugated bilirubin, and therefore does not allow screening for neonatal cholestasis. Number 4. An infant, like I said before, may initially grow and gain weight normally. This apparently reassuring early course should not delay the investigation of prolonged jaundice. And number 4, as I mentioned previously, an infant may initially grow and gain weight normally. This apparently reassuring early course should not delay the investigation of prolonged jaundice.
Yeah, thank you very much, Laura. So now I think I will summarize the key points I want you to remember related to the screening of biliary atresia. There's some. Biliary atresia, you learned it, is a rare but rapidly progressing neonatal liver condition with outcomes tightly linked to early identification. So screening is essential. The Kasai port ventrostomy is far more effective when performed early, the best before 40 days of life. So key screening signs to recognize in newborns is jaundice, pale stools, and dark urine. So please observe the baby's poops. If the neonate is jaundiced after 2 to 3 weeks of age, measure total and conjugated bilirubin. Elevated conjugated bilirubin is a key to early detection of biliary atresia as a sign of cholestasis. And if cholestasis is present, urgently inject vitamin K to prevent cholestasis-associated bleeding risk. Any suspicion should prompt immediate referral to a specialist. Delayed diagnosis leads to cirrhosis and liver failure. So in summary, effective screening programs are critical to avoid rapid progress of the disease and the need for liver transplantation. So now, let's move on to the diagnosis of biliary atresia and discuss best practices. Philip, which lab tests should be performed to diagnose biliary atresia and which basic lab tests are needed to exclude other conditions? We are now here in diagnosis and not screening.
So let's discriminate. So maybe first the baby will just be presented at the pediatrician, and then afterwards, if there is direct hyperbilirubinemia, the baby will be transferred to the specialist center. So now, the first scenario at the pediatrician. So the pediatrician should take the bilirubin level with the differentiation of bilirubin into direct or indirect. He will also test for gamma GT and ALT-AST, the liver enzymes. So now we are already coming to this kind of pattern recognition because there are some rare liver diseases, for example, having the picture of severe cholestasis, which means increased direct bilirubin, but the gamma GT levels are very low. This might be an indication for a very rare genetic liver disease. So now comes the second scenario. So the baby will then be transferred to the specialist center. And there we need some more lab workup in order to rule out other underlying diseases. So number one, we should check for alpha-1 antitrypsin deficiency, which is very easy. It's also just a small drop of blood. Then at least we do that. You should rule out cystic fibrosis, because cystic fibrosis can present with a whole variety of symptoms in the neonatal age. So cystic fibrosis needs to be tested for. And then, of course, as I just mentioned, we need to be aware that there are very rare, sometimes ultra rare genetic cholestatic liver diseases. And in such a case, a rapid genetic analysis might also be performed. But this can only be offered in the highly specialized centers.
So thank you, Philip. So indeed, there are many differential diagnoses, and not every yellow baby has biliary atresia. But now, Muriel, what are the challenges in distinguishing biliary atresia from neonatal jaundice in healthy infants?
Yes, beyond clinical signs, meaning pale stools and dark urine in cholestatic babies, laboratory evidence of cholestasis is also essential, meaning high conjugated bilirubin. It's different from physiological jaundice, which is high unconjugated bilirubin. And in cholestasis, there is high bile acids level, on the contrary of physiological jaundice, which is normal. And in cholestasis, there is high GGT level, and this is different in physiological jaundice, where GGT are normal for age.
Indeed. So lab work do help us. But now we will not just stop with doing some lab tests. Muriel, you want to comment on imaging and how this can help with the diagnosis of biliary atresia?
Yes. When the first step shows biochemical cholestasis, the second step is imaging assessment. The first step is the liver ultrasound, and it should rule out intra and extrahepatic bile duct dilatation. To find an abnormal or normal gallbladder, most of the time abnormal in biliary atresia, look for biliary atresia associated malformation, meaning polysplenia syndrome or other visceral anomalies. Endoscopic retrograde cholangiography is also another time of imaging that can help to demonstrate absence of bile duct opacification, but it's not available in all centers, and only few centers can perform this exam at this young age. Other imaging can be of limited values, as MRI poorly depicts the biliary tree at this age, and hepatobiliary scintigraphy that shows cholestasis, but that's not confirm bile duct obstruction.
So actually, basically, we need a good ultrasound, and that needs to be done in expert hands. Philip, you have other imaging you do in your center?
Yes, actually, so it's it's an alternative to ERCP, to the endoscopic retrograde cholangiography. Our interventional radiologists, they perform a transhepatic contrast injection into the gallbladder remnant in biliary atresia, also for direct cholangiography.
That's kind of interesting. And it seems that it's not all over the world that this is used. So thank you for this input. There's another thing we always discuss about diagnosis of biliary atresia, and it's liver biopsy. I asked this question to Muriel and Philip as well. Could you both comment on the role of liver biopsy, the pros and the cons of liver biopsy in biliary atresia diagnosis?
Yes,
Yeah.
in France, most centers do not perform liver biopsy as the first step, because liver biopsy shows signs of obstruction of the small bile duct, of course, but it does not definitely confirm the diagnosis for biliary atresia, and is an additional step that can delay diagnosis and the Kasai procedure. So we perform first early laparotomy and to perform Kasai procedure in the same time if it's confirmed.
So, in fact, we regularly perform liver biopsies, and at our center, I can take the biopsy today, and tomorrow in the morning, I will get the first results of histology. And typical histology in biliary atresia with pronounced ductal reaction and bowel plugs support the diagnosis of biliary atresia. However, if there is, for example, marked inflammation or giant cell transformation or hemophagocytosis, for example, this may indicate other diagnoses. But I mean, I fully agree, Muriel, that histology in biliary atresia is not 100% sensitive and specific. Absolutely.
Though there are always pros and cons, and there are always schools they will say we do a liver biopsy and others don't. But I think what is most important, as you said, we need 100% sureness that we have biliary atresia. And so to be 100% sure, we need to know if the bile ducts are open or not, if they're patent or if they're blocked. So the evaluation can be done by the intraoperative cholangiography. It's considered the gold standard for diagnosis of biliary atresia, with or without liver biopsy before, but we need a cholangiogram to be sure that those ducts are patent. If non-invasive investigations do not with certainty confirm the patency of the bile ducts, invasive cholangiogram is needed. Well, this can be done in different ways. You can use ERCP, and as you mentioned it before, this is not done in many centers in Europe, but still it's done. For those who have a program, that's wonderful. But then you can do it laparoscopically if you have kind of a gallbladder which is there, or very most often we do it with a mini laparotomy, a 2 centimeter incision, and you inject contrast into the remnant of the gallbladder, and then you know, yes or no, there's a connection to the duodenum, and there's a connection to up to the liver to the intrahepatic bile ducts. And then you know if there's a connection, it's not a biliary atresia. But if everything is blocked, then you know this is biliary atresia, and you can immediately, during that mini laparotomy, go into a either bigger laparotomy, or you can also do a laparoscopic Kasai. But what then can be done under the same general anesthesia, you need do the Kasai surgery as a first step procedure to cure, quote, biliary atresia. So, Laura, you want to add to mention something about the diagnosis of biliary atresia?
Children with suspected biliary atresia should be referred as early as possible to an expert center experienced in the management of biliary atresia and in performing Kasai procedure. This is very important for two reasons. First, to allow rapid and accurate diagnosis, and second, because the success of Kasai procedure is higher when it is performed early and in centers with extensive experience in this surgery. It has been mentioned earlier, but another important point is that in case of suspected cholestasis, vitamin K should be administered to prevent bleeding complications. It is safer to give vitamin K even if cholestasis is not confirmed than to risk not giving it in a baby who actually has cholestasis.
So thank you, Laura. Thank you very much. I think input from our parent advocates, patients advocates, and parents is so very important because together we are the team for our patients, and in biliary atresia patients even more important. So now regarding the diagnosis of biliary atresia, I think these are the key points we want to remember. Laboratory workup, we need to measure conjugated bilirubin, bile acids, gamma GT, which are all elevated in biliary atresia, unlike physiological jaundice where only unconjugated bilirubin is raised. If lab workup confirms cholestasis, you need to proceed to imaging. Liver ultrasound is the first line imaging. Watch for abnormal gallbladder. Rule out intra and extrahepatic bile duct dilatation, which would exclude biliary atresia. Assess for biliary atresia associated malformations such as polysplenia. And of note, Important to remember, MRI on the HIDA scans are of limited value at this age. And then liver biopsy is not routinely recommended as a first step, but it can suggest obstruction but does not confirm BA, and it risks to delay diagnosis of the Kasai procedure. But if you have, as Philippe in his hospital, if you have a very quick liver histology, you may consider liver biopsy. But when biliary atresia is highly suspected, early laparotomy with simultaneous biopsy at Kasai is preferred. And again, the gold standard is cholangiography, which confirms or rules out the diagnosis of biliary atresia. So, in summary, the key principles again refer early to an expert center experienced in biliary atresia management and Kasai surgery. Again, outcomes are better when the procedure is performed early and in high volume centers. Now, we have discussed about the gold standards, about what we really need to do for our patients. We need to watch out for poop, and then we have to react if the poop is pale. But now, Muriel, Philippe, are there any evolving approaches for the diagnosis of biliary atresia?
Indeed, in France, as a yellow alert that can be can aware for color stools, and we need to do more campaigns, and also perhaps incorporating AE-based stool color analysis to help with early diagnosis also.
Yes, actually, maybe I can just add a little bit on the AI-based tool color analysis for early diagnosis. So we are currently working and trying to establish this kind of approach. So we developed an AI-based tool color analysis tool, and actually we aim for introducing this kind of stool color analysis in the regular follow-up of newborn babies. So this might be helpful, but clinical studies are on the way. Maybe I can still comment on the aspect on the quality of care initiative from Biliary Atresia. So this initiative was started by Aspigan members in 2024. And the colleagues, they first took a survey, a European-wide survey about the age of children at Kasai procedure, for example, and turn out that the Kasai procedure is done in Europe at about 60 days of life. And I think what was pretty much interesting that the centralization to take care of children with biliary atresia is not very developed, meaning that in 44% of the centers, only or less than 5 Kasai procedures are performed per year. I'm not a surgeon, but Barbara, you can comment on that. I mean, I think it's very much important to be used to do a certain procedure, right?
You're absolutely right. And there's actually a literature out there that the more you have experience, the better you do Kasais and other operations. And that's why we say experience centers need to take care of our biliary atresia children because it's related to outcome. You're absolutely right. So thank you very much. I think we conclude here. And at risk of being repetitive, what I want you to remember is the following. The consequences of delayed or misdiagnosis is that biliary atresia progresses rapidly to biliary cirrhosis, liver failure, and death within the first years of life. Delay again reduces the efficacy of the Kasai surgery and increases the risk of needing liver transplantation. And as for screening, observe stool color in every newborn. Pale stools and dark urine are red flags. In any doubt, measure total and conjugated bilirubin and detect cholestasis. If present, give vitamin K and refer the patient to a specialist. As for diagnostic pathways, you need to confirm by cholestasis biochemically with conjugated bilirubin, gamma GT, bile acids. You do a first-line imaging with liver ultrasound, plus minus liver biopsy, And then the gold standard, you do a cholangiography. Refer early to a high volume expert center. Timing and experience saves lives. The key message, again and again, early recognition, prompt referral, and a structured diagnostic approach are the most powerful tools to improve outcomes in biliary atresia for every clinician at every level of care. Thank you, dear colleagues. It was a wonderful discussion and a pleasure to talk to you. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.